Hello, welcome to Heartland Cares HIV 101. I'm Krista Wood, the Executive Director, and today I have two very special guests. I'd like to introduce Dr. LeBuhn and Dr. Anita Fleenor. Thank you all for being here today.
You're welcome.
You're welcome.
So y'all have been working in HIV for how long?
I've been here in Paducah for 10 years and 2 years prior to that in a fellowship, infectious disease fellowship, so total of at least 12 years.
12 years. Dr. LeBuhn?
And I moved to Paducah in 2000, and before that I was 3 years at the University of Iowa in HIV care, and before that I was in fellowship training in HIV care, so somewhere around 13, 14 years.
So I guess y'all have seen a whole lot in that time span. A lot of changes have taken place. I know you've been at the clinic since it was founded, so I think we started with, how many clients did we start with?
Just over 40.
Over 40, and now we have?
We've seen well over 600 based on our chart numbers, but probably about 300 active clients.
And that's amazing. I know people don't even know we're here a lot of the time, let alone that we've got that many people who are clients. And we're not the only ones who serve HIV, so that's not all of the people who may be positive in our community. So what is the percentage of people? How do we estimate how many people we might have who are positive or who know they're positive in the area?
It's a little hard to know exactly what percent of our entire population is HIV positive, but if you can usually say that if you have 300 or 350 people in care, there's at least one person out there who's not in care, and some numbers would suggest it's a little higher. So some would say that if you have, for every person you have in care, there's one person who knows they're HIV positive and not in care, and one person who's HIV positive and doesn't know it at this point. So you can probably take the number that you're providing care for and multiply it by 2 or 3 to get a little more accurate representation of what's out there.
And I guess the first thing I'd like to talk about is some people say AIDS and some people say HIV, and so what is the difference between HIV and AIDS? What is HIV? What is AIDS?
Well, HIV stands for a human immunodeficiency virus, and that is actually the virus that's infecting the person who has that disease. They can have that infection much like anyone can have chicken pox or influenza, another type of virus, and maybe get over an initial illness, but still with HIV they continue to have that virus. Different people have different levels of the virus in the blood. However, it may stay inactive for a while, so to speak, or they may progress with that. If there's progression anywhere from months, maybe a couple of years, to may take several years, decades to progress, they may have what's defined as AIDS, and that's actually where they have a clinical disease from having the virus. Strictly, it's defined as if their T cell count or CD4 count, which is something we'll talk about, I think, in a minute or two, gets below a level of 200, and that's kind of a marker for us that their immune system now is at grave risk for infection and malignancies and that type of thing.
Wow, you've said a whole lot, so I'm going to try and break it down a little bit because I think it is hard. With HIV, you said that it's the virus that can be in your body and you can have symptoms or not have symptoms. So can you all explain that a little bit more?
Somebody, when they're first infected with HIV, the human immunodeficiency virus, can have symptoms of a mono-like illness or kind of like an influenza-like illness. That can be a sore throat that lasts for a couple of weeks, swollen lymph nodes in their neck or in their armpits or in their groin, an unexplained fever, sometimes a rash, sometimes some neurological symptoms. And so, but not everybody when they're first infected with HIV virus has symptoms. After that initial infection, the body's immune system starts to try and fight the virus and usually starts to control that infection on some levels. And so while that immune system is fighting that virus, people can live many years without any symptoms at all. And Dr. Fleenor mentioned the T cell count or the CD4 count. With time, the HIV virus will make that T cell count lower, and the lower the T cell count gets, the higher somebody's risk for certain types of infection or certain types of cancer that are related to HIV infection. So after many years, sometimes decades, they might start developing complications of HIV. And when that T cell count is below 200, they would have AIDS or acquired immune deficiency syndrome. If they're HIV positive and have cervical cancer, or HIV positive and have pneumocystis pneumonia, or HIV positive and have esophageal fungal infection, for example, then they would be diagnosed with AIDS also. But even if their immune system, and we'll talk more about treatment I think later, has progressed to the point of somebody having AIDS, that to us as clinicians doesn't mean as much anymore, because the things that we have to treat HIV infection or AIDS now are so much better that people can lead very, very productive, happy, comfortable lives, even if they've had a lot of progression of their disease.
Okay. Well, let's kind of go back a little bit and talk about the diagnosis, how we get that diagnosis. And I know that there's a lot of different types of tests now that we offer at the clinic. So what kind of tests and what do they mean? How do we know when that test is positive?
The traditional tests that we still do a lot are the blood test, and it's an antibody test, and that's basically testing for the fact that your body has seen that virus and made a response to it.
Okay.
Similar to if someone gets a vaccine for hepatitis B and then they're checked a month or two later to see did that vaccine work for them, did they respond to that. However, with HIV, this antibody response is telling us yes, they're infected with that virus. And that generally takes 2 weeks to get back if you do it traditionally, where you get the initial screen and then you confirm that. And as you mentioned at the clinic, there are tests. Now there's a oral swab test that the result can be back in 20 minutes. I don't think that's used very widely anywhere else. And health departments, I believe, are all still using, or at least locally, the blood test.
The blood draw.
So a huge benefit for someone to get that result right when they get tested 20 minutes later and they don't leave. There's no chance of losing them. You know, you've got that captive audience.
That's great. And then if the test is positive, it's based on, is it based on those helper cells, the level of those helper cells, is that what they call the CD4 cells, the helper cells?
There's sort of two different things. The HIV test is measuring proteins that your body has made to fight the HIV virus.
Okay.
And so how much you have to get so much of that protein made by the body to fight the virus before your test will be positive. So the test itself is looking for, as Dr. Fleenor suggested, a response, your body's response, or proteins your body's made to fight the infection. The helper cells are your own white blood cells or your own infection-fighting cells, and those cells are what the HIV virus attacks. So a normal person might have 700 or 800 CD4 cells on average, or helper cells on average. Somebody who has advanced HIV infection would have less than 200 or less than 100 or maybe 50 of these helper cells to help fight infection. So the test measures for a body's response or proteins that your body's made to fight the infection. Another type of blood test measures kind of how strong your immune system is, or how stout your immune system is.
Okay, and you had said that that virus could show symptoms, or it could not show symptoms. So if someone came in to take a test, if they didn't have symptoms, we would and they had risky behaviors, we'd still want them to get tested. Then it's not based on symptoms.
Absolutely. I think most people are not symptomatic until they progress to advanced disease, or the terminology AIDS we use, and we have plenty of people whose CD4, we also call it the T cell count, the helper count, is in a single digit and they weren't symptomatic, or that's the first time they became symptomatic. It's well below the 200 level. So I think that's definitely true, much like hepatitis C or some of the other things that we hear about. People had no idea. People have high blood pressure or diabetes and they say, I felt fine. Along the same lines, people can feel fine and have HIV.
And so we're in the third decade of HIV and AIDS virus. And is it possible that someone could have been infected early on in that first decade and still not have symptoms? Is that a possibility?
It is a possibility. There are some people with HIV infection, and they're kind of the term used as long-term non-progressors. They've been HIV positive for many years, but their T cell counts or their CD4 counts have never really declined. And there's a variety of different factors, some of them genetic, some of them how healthy they are otherwise, kind of a whole host of things that are probably contributing to why they didn't have progression of their disease. And those people are being studied to try and figure out what are the characteristics that keep the HIV virus from attacking them as hard as it does some other people. That's the minority of patients who have HIV infection, probably maybe 5 to 10% at most, who would be long-term non-progressors over 30 years.
So then, to the audience, the most important thing is if you have any risky behaviors at all, and what are we looking at as far as risky behaviors? We have a slide that we can put on for the audience, but let's talk about them just for a few minutes, the behaviors that cause HIV.
I can start and mention a few, and then I'll leave the hard ones that I forget for Dr. Fleenor to come up with. But sexual contact or unprotected sexual intercourse with a man or a woman would be a risk factor. There is a risk of sharing needles for people who have injection drug use. If you share needles with an HIV positive person, and those would also be risk factors for hepatitis.
All hepatitis? All of the hepatitis?
Basically all of them,
okay.
Yes. The occupational exposures, so people who work in the medical or other professions where blood exposures to non-intact skin or to mucous membranes. There is a risk of transmission from an HIV positive mother to the unborn child if certain measures aren't taken during delivery and after delivery. Body piercings where non-sterile, non-unique, where equipment's been used on more than one person for body piercing or tattoos or those sorts of things.
I think you said most of them.
You did a good job.
The one issue that's been highlighted recently is sharing of inkwells and with the tattoos, and I think that's less of an issue. And I'm questioning people. I'm amazed at how many people say I opened my own needle when I was there, and they had me open my own inkwell. So the patrons tend to know. And that's pointed out to them, it seems like, at the licensed tattoo parlors. A lot of people still do tattoos in their home, or a lot of incarcerated folks, we see them with tattoos that they do while they're incarcerated. And then there was a hepatitis case of someone sharing piercing, and I think it was a navel piercing or maybe on the face, not earrings, but after they had that piercing, they shared it with a friend. They swapped out their navel ring, and there was a case of hepatitis B with that. So that's something I think we hadn't really thought of much about. A lot of teenagers swap out earrings and clothes and that type of thing. And
the one that I've heard a lot about as far as not understanding why or how is breast milk nursing. How is that? Because it's bodily fluid, so I guess that is a bodily fluid, but it's digested, so.
Right, it is, and because it's generally not, we don't see it in the saliva generally as far as a transmission, unless someone has blood in their saliva. But as far as breastfeeding, and not too much an issue in the United States, but it is recommended that any pregnant mother, or once they deliver, that they do not breastfeed. In third world countries, it's more of an issue because there's starvation issues and access to clean water, and so that's being looked at heavily in Africa and other countries about how can we prevent transmission. But it is detected in breast milk.
And then with the transmission, the perinatal transmission, we've done a really good job in this past 30 years of reducing that. How have we done that? What is the procedure on that?
It's very important for women who are pregnant to consent and receive HIV testing early in their pregnancy and throughout pregnancy if they have risk factors that could lead to HIV during their pregnancy. The risk, if a woman is HIV positive and has no treatment and her child has no treatment after the child is born, the risk of transmission of HIV from mother to child is somewhere between 20 and 25%. And however, if the woman is diagnosed with HIV, is put on medications in the second trimester of pregnancy, which she will take throughout pregnancy, the baby or the mother is given an intravenous medication called AZT at the time of delivery, and the baby takes medications for 6 weeks after birth, that risk can be diminished to less than 2%.
Wow.
And so a huge advantage to knowing that you're HIV positive and getting appropriate care during pregnancy and in the postpartum period.
So from 25% to 2%, that's profound.
Or less. I mean, I would even say less than 2%. I mean, I think if all those steps are taken and that woman stays plugged into healthcare during that time frame, the odds are very much stacked in favor of a good outcome in terms of the delivery. And there's a much longer track record with the medications being developed to know which of the HIV treatments that we have that are safe during pregnancy. And the majority of what we have are relatively safe to administer during pregnancy.
And so I'm beginning to hear a constant theme of it's important to be in care. It's important to know your status, and it's important to be in care, because that can make all the difference in your own health as well as, maybe even a baby's health.
And I think you brought up a good point about consenting to be tested, because a lot of people think they're
Yes.
tested, and they're not. It's not law. There are certain states that have law about mandatory testing of pregnant women, but most of them do not. So it's still voluntary. And many of the obstetricians do go ahead, and that's part of their routine, but not everybody does.
Mm-hmm.
And they may make an assumption that we all do, that we're not going to test that person or we don't want to offend them. And a lot of people think when they go to the hospital they're tested. A lot
Right.
of people say, well, they did all that blood work, surely they did an HIV
Mm-hmm.
test. And so they may need to insist on it, or just say, by the way, did you do an HIV test? And he also brought up at the beginning and maybe throughout pregnancy, and that's been highlighted a little recently, that maybe their initial battery of tests when they're pregnant in their first trimester includes an HIV antibody test, but then there's some people that acquire it during their pregnancy. So if they're not tested again at the end of pregnancy, you can't
Wow.
provide them the treatment or the baby the needed treatment.
So that counseling that goes along with testing is crucial if someone's of childbearing age and is sexually active and not using protection or trying to conceive a child.
Correct.
Kind of on that theme about, testing during pregnancy and things like that, and is that, though, I think some people live in fear that they had an exposure 10 years ago, and that, they worry about getting HIV tested and things like that. If you had an exposure a year ago and you test HIV negative now, you're not ever going to be positive from that particular exposure. So, usually if you're exposed to somebody with HIV today through sexual contact, through injection drug use or sharing needles or whatever the exposure may be, if you're exposed today and you test negative in 6 months, then you were fortunate not to have contracted HIV from that particular exposure.
And so are we going back we can confirm a negative test as of 6 months ago? Is that the standard? Or can we detect if someone's negative or positive sooner than that now with the way that our tests are?
You can detect sooner. They may be tested sooner, and everybody has, they have some different guidelines about when you test. And some people want to be tested more frequently, because if they're tested initially, after an exposure, whether it's occupational or sexual exposure, they may be negative. And then if they're tested again at 6 weeks, and then 3 months and 6 months, a lot of people are nervous about that, and I can see why, and want additional testing sooner. But they may convert any time in there as quickly as 2 weeks, 3 weeks after their exposure.
Okay.
And you brought up the counseling, which I think is important when you talked about someone coming in for testing after an exposure. And I know that at the clinic they're counseled that you have to come back. And I think that was when it takes a time for your body to build up the antibody, that protein, to be detected in the blood. So you may still be developing that. Our test is not positive yet. Okay. So there's a reason for testing, continued testing, the same way that we test the babies once they're delivered. They're tested out generally to 18 months, the babies are.
Okay, so we've talked about the tests and it's very important to come in and get tested if you've had any risky behaviors. And then we provide all of those tests for free at the clinic, and we do walk-in tests. And then we also have a prevention team that will go out into the field if people aren't comfortable coming in. So, and we test a lot. Our tests, I can remember it being a very lofty goal to have 100 tests a year. And now we're doing over 100 tests a month easily. So I think that's good. I think we're doing a good job, because there's a lot of talk, and people ask me a lot, and I'm sure you're asked even more. Like I've heard about a vaccine, or I've heard about a cure. Is that a myth, or what is that about?
I'm going to say yes and no. They did work on a vaccine, but they recently stopped the trial because the vaccine doesn't look like it's going to be efficacious, or it's not going to be useful. So they're going to have to redevelop some different vaccine strategies. So yes, it's true they were working on a vaccine. Unfortunately, it doesn't look like it's going to be of benefit. And is there a cure? It depends on how you define cure, and that's why I say I consider HIV almost curable at this point in the sense of how treatable it is. We have, when Dr. Fleenor and I first started in training, there was maybe 1 or 2 medications available to treat HIV. Now we have upwards of, I wish I knew the exact number, but probably 15 or 16 from 5 different classes. And those medications can be used in combination, and they are highly effective. So, whereas in the past, if you contracted HIV, you might develop AIDS or even pass away on average in 10 years. I think life expectancy for the majority of people now is going to be measured in decades, if not many decades. So I think for a lot of people, they're going to have a normal life expectancy. So is it curable? No, it's not curable. But is it manageable so that people can have high quality of life and continue to work and enjoy their families and take medications that are much better now than they were before and not have a lot of side effects? Definitely. So I think technically it's a myth that there's a cure, but it's not a myth that it's manageable.
So it is treatable, and
Absolutely.
It's, I believe, called a chronic condition now. Is that how we define it for a pretty high percentage of people?
And even someone who presents with advanced HIV, AIDS, even extremely ill with an infection, can still be treated and be managed chronically. We've had a lot of people extremely ill that survive and are back to work. And a lot of success stories like that. So I think that you can't take someone on a ventilator who's extremely ill with no T cells or very little and give up. You just can't.
So that brings me to Magic Johnson. If we're talking about cure, because that's the rumor I think that the general public hears, is that he's cured, and that if you have enough money, you can be cured from this disease. So, what are they talking about with him? He's probably a good example of what you were saying.
There's kind of a couple of different, we mentioned before the T cell count or the CD4 count, and that's a way of measuring how strong someone's immune system is. And so a lot of times when you get on medications for HIV, we can see a T cell count or a CD4 count rise up into a way that they have more protection. Their body has a stronger immune system. But once we put people on therapy, there's actually a different test that's probably more important to follow, and it's called the viral load. And it's a way of measuring how much HIV is in somebody's bloodstream. Usually before we start people on medications, the viral load is usually fairly high. And now, once you put them on medications, you follow that viral load. And in 3 to 6 months after starting medications, you like to see the viral load become undetectable. And that's kind of what we look for. We want to see a very aggressive response to the medications, and that's an undetectable viral load. So in essence, we can't find the virus in the bloodstream anymore. We know it's still there in lymph nodes and in other areas, but we've suppressed it so much with the medication that it's undetectable. So people like, I don't know anything about Magic Johnson's laboratory work and his history, but probably he's on a good combination of medications. He's probably taking his medications as prescribed. He's probably not missing any dosages of medications. And because of his adherence to his medications, his viral load is probably staying at an undetectable level. And his doctors have been, with his help, with Magic's help, have been successful at kind of stabilizing things so that hopefully he'll have an undetectable viral load for a long time and won't have any progression.
And so does that have anything to do with his money, or does that have to do with his care.
I doubt it has anything to do with his money.
Thank goodness.
Yeah, I think, we all talk about access to medications, and you hear about it more with third world countries, about lack of access to medications. And we've had our own battles here, obviously, in the United States. Different states have different formularies of medicines and help provide funding for medications. But in general, through state programs and the pharmaceutical companies, people that have needed medications, they've gotten their medications. So money, whether they have money like Magic Johnson or not, they've been able to get the same medications that Magic Johnson has the opportunity to get.
So that's very encouraging.
And I would have to just echo that and say that I really haven't had somebody who I've wanted to get on medications not be able to get medications. They sometimes have had trouble staying on the medications because they don't have a home to live in, or because they are moving around a lot, or because they've been, in some instances, in and out of jail, or
Have to hide it from their families.
or in some instances have been concerned about stigma and those sorts of things, so they've hidden it from their families. Those sorts of factors that have been and more important than whether they have enough money to buy the medications. And these medications aren't something that you can sort of take 2 days a week or 3 days a week, or if you're going to be on medications for HIV and they're going to work, you have to get greater than 95% of the dosages in on time. So
For the rest of your life.
For the rest of your life. So being strictly adherent to the medications is critical for them to be able to work and do what they do. Now, having said that, when Dr. Fleenor and I were, in training and early in our careers, a medication regimen might include 15 pills given, 3 times a day, 4 times, 2 or 3 times a day, sometimes 4. Now we have a regimen that's very strong, very potent, highly effective. That's 3 medications combined into a single pill, and it's 1 pill once a day. So the majority of treatment regimens we can put somebody on now are once a day. There's no more 3 days of 3-day regimens. Some are twice a day, but the majority are once a day. And most are somewhere between 1 and 4 pills a day. So they're very, very tolerable, for the most part, quite easy to take.
So as far as side effects of medications, when you take the medications, I know in the past, if we look at over the past 30 years, there were horror stories of people not being able to keep the medicines down, having profuse diarrhea all the time, not being able to leave their homes because they were afraid that they wouldn't be close enough to a bathroom. Is that still the case, or has that improved as well?
I think that's improved a lot. We know more about anticipating how to treat some of the side effects, and do a lot better job, I think, of counseling ahead of time about that. But there are still some medications that may cause the stomach upset in some people. And we have to remember, we have some people they're in their 3rd decade of this. So they may not be fortunate enough to take the 1 pill once a day. They're on a more complicated regimen because they may have been through a series of medications. And they may have to take that one type of medication that causes, a lot of diarrhea or nausea. We can generally try to treat with medication for those side effects and anticipate that. And a lot of that was maybe not because they were not adherent in the past, but that's one thing Dr. LeBuhn brought up. Our focus on adherence was not there 10 or 15 years ago like it is now. And now we see that how strict we are, and if maybe we would have been able to be that way 15 years ago, they would have more choices than they do today. But they may have taken their medicine and missed a few doses, or taken 80% or 70%, and we may have not have been so forceful about saying, no, you do need to call me on a Sunday if something's going on, and not wait till Monday.
That a lot too.
It is Thanksgiving holiday, but we do want to know. We will call in your nausea medicine for you, and that type of thing. So it's kind of evolved, and I think we've improved on that. But there are still some side effects, but generally I try to ask people up front, what are you worried about? What have you heard? Because they have their stories.
Yes.
And some of the medication doses are quite a bit less. AZT was 5 times a day, and it was twice the dose it is now. 15 years ago when it first came out, and people were sick. They were walking around carrying a cup because they were throwing up. Another medication They had to drink at least a liter of water every time they took it. It had to be on an empty stomach, and it caused kidney stones if they didn't. You know, a lot of those things that it's hard to do for anyone.
So a couple of things. We've been talking a lot about adherence. And so how would you define adherence? Because that's not a common term unless you've had some kind of chronic condition like high blood pressure or diabetes or something. You might not be familiar with that term. So talk to me a little bit about adherence.
Adherence, I think, to me just means keeping up with what you need to be doing. And so adherence could be adherent to your clinic appointments, making sure that you're and generally we want to see people with HIV a minimum of 3 to 4 times a year. And that's how we measure blood work and check on things and things like that. So adherent to appointment, keeping appointments. Adherence to medications, not missing dosages of medications, not varying the times of day that medications are taken. So making sure that they have steps in place, alarm watch timers, for example, or supportive family members to act as a reminder, or a friend to remind them regarding taking their medications, adhering to the medications at the time they're supposed to take them, to take them each day. I think it's important for them to adhere to risk factors regarding HIV. So to take responsibility to inform any future sexual partners that they're HIV positive, to adhere to using a barrier protection method like a latex condom if they are going to have sexual intercourse or sexual activity of some kind. So I mean, adherence to me kind of covers all those different areas. Highlight one other thing regarding treatment. We talked a little bit about the medications and single pill and the lack of side effects. I think probably half of people I start on medications now really don't have any appreciable side effects. So, and then the majority of people who do have side effects, they're very easily manageable. It's the minority, probably 5% of less, that I actually have to stop the treatment because they can't take the side effects. So it's manageable. And I think the other thing that people need to be aware of regarding treatment is that we don't have to start medications on everybody. It used to be we started medications on everybody who is HIV positive. It's gone through a variety of different recommendations or national treatment guideline recommendations, but the current guideline is that we don't start treatment until the T-cell count is less than 350. So we have a lot of clients at the Heartland Clinic that we're following who we see every 3 to 4 months. We measure laboratory work, we assess their symptoms, but they don't require HIV medications at this point in time.
Okay. And so when you've talked a little bit about making sure that if someone is positive and they're sexually active, that they protect themselves and protect others. Is that related to adherence? Is that as far as the amount of virus in the body, it being more likely or less likely? Have we been able to prove that, or is that one of those myths? Because I know I hear both sides of that, and I know I think sometimes we're afraid to talk about things because knowledge will cause people to do things we may not want them to do, but I think knowledge is important. And
it does make a difference as far as transmission, just like we talked about with mother-to-child transmission. So reducing the viral load, and that mother will reduce the chance of transmission to the baby. And we do know that a lower viral load decreases the risk of transmission for sexual transmission. There are some interesting studies that look at semen and vaginal fluid, and someone can be undetectable as far as their blood work, but still have a very large amount of virus in the body fluids that you're concerned about. So we still have to obviously recommend a barrier method of protection, like Dr. LeBuhn mentioned. But there, some public health folks have looked at the fact of, do we need to be starting everybody on treatment just for public health reasons to get the viral level down and maybe decrease transmission? That's a whole different ballgame in cost and side effects.
And so we've got a couple of slides that I think is important to show right now. One, what causes HIV and what does not cause HIV, so that, because I think this is a pretty complex topic, and I know it's very difficult. I'm sure as infectious disease specialists, how much time do you have to spend just keeping up with and researching to be able to provide the wonderful care you provide for the clients in our service area? What does that entail?
I don't know how to quantify it time-wise, but to say that just you know, we do gain some degree of experience with every person we've treated, and that everybody's different, their circumstances are different, their combination of medical problems is different, and so you sort of learn different ways and managing things, you know, as you are reading, as you are gaining experience. We talk very frequently about patient care. I mean, we work together on difficult cases to help design treatments that we think will be ideal for that person. Sometimes we use tertiary centers like Vanderbilt or Louisville or Lexington to present certain cases and information at case conferences so that we can get input from other providers. Those are kind of the different avenues we do to sort of keep up. We try and, you know, follow the treatment guidelines and all those sorts of things. But
so you have a network of care as well.
And there's been a lot of new medications come out over the last number of years. Dr. Fleenor, I think, mentioned that our dosing of medications is different. So, I mean, there's a lot of changes that are going on in the field of HIV management.
And so if we looked 30 plus years ago, and we had nothing to offer someone with HIV or AIDS, all we could do is treat what their immune system that was no longer effective caused, like the pneumonias you're talking about. So all you could do was treat what we call opportunistic infections.
Right.
And then the miracle drug, I think we're still using it for AZT. And so it wasn't a miracle drug by itself, is that correct?
And it probably bought some time for some people, but you know, one drug alone, we've learned that you need to use different targets for different sites where the virus is involved to be able to minimize resistance to that medication. So it's kind of like penicillin was used extensively starting in the 40s and 50s, and now we can use penicillin we can't use for very many things anymore just because it's used extensively by itself, maybe overused a little bit over the decades, and that's the way AZT has been, but it's still useful for some things. So AZT and some of the other drugs that were second and third line have kind of gone by the wayside because of side effects and because other things have just replaced it. But AZT is still a lot of our core basic regimen, and is still what was proven to decrease the transmission to mother to child, so we still give it intravenously at the time of delivery.
Wow.
If you look at the last 30 years, kind of what you were, they can show graphs, and let's just take, for example, in 1982, if you had 100 people with AIDS, so advanced HIV infection, there was only about 10% of those people that would be alive 5 years later. Then they started to give medications just to prevent the opportunistic infections. So, for example, Bactrim, a simple antibiotic given once a day to try and prevent pneumocystis pneumonia. So that's an example of just a preventive medication. That sort of came out in the late 80s. So if you took 100 people who had HIV or AIDS that were diagnosed in, say, 1988, you might have 20% or 25% alive at 5 years. Then AZT came out, and that kind of gave a similar little bump like Bactrim did, so maybe 35%. The real breakthrough came in the mid-1990s when they developed a third class of medications called protease inhibitors. And people, rather than using a single medication like AZT, and then when that failed, a new single medication like DDI, started using 3 or 4 medications at the same time. So attacking the virus at 3 or 4 different ways at the same time. And then what you can see starting from the mid to late 1990s on is that if you have 100 people who have advanced HIV infection, 70, 80, 90, now 95% of those people will be alive 5 years from now if they stay on treatment. So that's been sort of the learning of that's gone on with managing HIV.
And I think we have a slide that shows that without treatment, the average lifespan is what, 10 years?
Probably without treatment, from if you were diagnosed with HIV today to when you would be diagnosed with AIDS or kind of the more advanced HIV infection would be an average about 7 years, and probably an average life expectancy of 9 to 10 years.
And then that beginning, what is the average of not showing symptoms, the average years?
Most people would be asymptomatic for probably 7 to 8
Wow.
years during that time frame.
Because they probably would not, until they progress to the diagnosis of AIDS at 7 years or so, that's probably when someone would start testing, or they would request testing. They wouldn't be tested otherwise.
And this is where I feel like I always have to say, we have to be responsible for ourselves, because yes, we need to be responsible for others, but you may not know, so it's very important to get tested and know your status. But if you don't know your status, you don't have any symptoms, then it's really hard to tell someone. And so we all really need to be using standard precautions because the only real way that we can stop the spread of the disease is through, abstinence first, and then protection as far as condoms and lubrication, and using safer sex practices instead of riskier sex practices, and don't share needles or tattoo.
And I think the majority
piercings.
is sexually transmitted, at least in this area. I mean, other areas, injection drug use may be more of a problem, but I think that is kind of a focus for this community at least. And we brought up the risk factors before, and we still say risky behavior. And I think a lot of people that test patients that then are referred to us are testing them because they suspect that they're gay. And I'm glad they're at least testing and thinking about it. And everybody falls into the stereotype. We all stereotype people, even though we may not mean to. But they may be tested for maybe not the wrong reasons. We're missing a huge chunk of the heterosexual population. But I think that the point about risky behavior, I think a lot of people don't perceive their behavior as risky. And so, boy, if anybody's ever had unprotected sex one time, go ahead and get tested, get it over with. You'll know, and you're done. Because, we try to tell, young people if they'll be pregnant or concerned about pregnancy, and it never crosses their mind that they could have HIV, or they're treated for gonorrhea, or they have genital warts, and even for some other providers in the area, it may not cross their mind when they're testing for other things that HIV needs to be included in that.
So if you can get pregnant, if you can get any STD, then you can get HIV or hepatitis. Am I saying that correctly?
Yes.
Okay, I think that's a very important message to give to the public, and that's what we're all about at Heartland Cares. And so if we have someone who's positive for a test, and we have a wonderful clinic with 2 wonderful doctors taking care of our patients, and we have a lot of other support services that I think support adherence, and we'll be talking about a lot of those on other shows. But what about the person? Because we know, one of my other things I like to say when I'm giving a talk is that, HIV doesn't kill anymore. Discrimination kills. We got to get people through. We got to get people tested. We got to get people in our doors into treatment as soon as possible to have that quality of life. And so, as a community, we need to be open to the fact that there are not the boundaries that we think there are in this community. As we look like every other community, except that I think in the South, we're considered part of the South, that we may be growing at a little bit faster rate. Is that correct?
I'd say our numbers of patients with HIV infection, our numbers of patients with AIDS is very average relative to the rest of the United States. I would say that our numbers in Paducah and in the surrounding counties of southern Illinois and western Kentucky are very much similar to what is in Louisville, as to what is in Lexington, as to what is in Memphis and other areas. So it's a disease that infects men and women, people who are rich, people who are poor, people who have any walk of life you can imagine, and people who live in rural areas.
People who are sexually active.
People live in rural areas, people who live in urban areas. And so I think a while back somebody agreed to be on a show anonymously, and it happened to be a woman and who was in her mid-60s. And when the reporter came in the room to film the show, she stopped and fell back on her heels and said, "You're not what I was expecting to see." And I wish that could have been what was filmed and put on television, because that is what we see all the time. And that's men in their 70s, women in their 60s, women in their teens, men in their teens, men, you know, people who are gay, people who are heterosexual, and we really see the full gamut of this epidemic in this area. I'd like to Dr. Fleenor to add to this too. We were talking a lot about risk and a little bit about stigma and those sorts of things. You can't get HIV. I think we ought to talk about how you can't get HIV, because there isn't a time, I don't think, it's probably at least once a week, somebody hears somebody talking in their workplace, making fun of patients who have HIV, and that makes them scared to go to their doctor, or people are just afraid to come to the clinic, or you know, we still hear of families who have ostracized somebody, you know, or aren't having anything to do with them because of HIV infection, those sorts of things. Now, I would say the majority of families are supportive and things like that, but not always. You can't get HIV from hugging. You can't get HIV from sharing the same toilet seat. You can't get HIV from sharing the same utensils at the dinner table, from sharing the same water glass, from mosquitoes, from even kissing, unless there would be a large amount of blood involved, or blood involved with kissing. So, you know, you can have, this is a disease that's transmitted by sexual contact, by injection drug use, not sharing the same airspace, not wearing the same clothes, and those sorts of things.
And I don't know how, when you talk about the stigma, and you know, how can we break through that? I don't know, other than trying to live by example. And you know, we see that a lot, and I'll say I wouldn't be walking in the room if it's a hospital room if I was concerned, or you know, when I was pregnant, people would say things. I'm like, do you think if I thought I was at any risk, I would be walking in the room, or let my children sit on someone's lap, you know, or they watch my child while I'm running by the clinic to do something? And I wouldn't do that if I thought there was any risk. But you can't always do that. And the other thing is, a lot of people, you know, there are people that are outspoken and willing to come forward. Like you said, the person you talked about, of course, was kind of shadowed because she wanted to speak out, but could not let her face be shown. And we all have to ask ourselves, would we be strong enough to do that to our families? And hopefully we would, and our families would support us. But, you know, until more people are able to step up and say that they're positive, and everybody can go, wow, I didn't expect that, and we have dialogue, I think we're going to be dealing with it.
I agree. I know I did a panel out here at the college for World AIDS Day a couple of years back, and one of the students asked, you know, what is it going to take, you know, to stop this disease? You know, the statistics say you're only allowed one unprotected sexual encounter a year, you know, to get it below a pandemic level, and that's really scary for me. But you know, my response to the student was, I hope it doesn't take, you know, it affecting each and every one of us in some way, that it has to get personal, that we're all actively involved in it some way through, you know, a family member or ourselves or significant other. I hope it doesn't get to that it would reduce the stigma of the disease. But I think that's very scary in itself. So people who are concerned about their jobs, are concerned about their families or their churches, where else can they go? I think it's really important. We want everyone to come to Heartland Cares, but we also want them to have choices. So what are their other options?
Right, and we do try to help them with that, because that's quite an issue. I mean, as far as people, you know, that's an extensive issue for how we contact people, if we can leave messages or not, how they contact us, you know, via cell phone, not. We block the phone so it doesn't show up. We try to do all that to protect them. We happen to have 2 satellite clinics, outreach clinics, one in Hopkinsville and one in Jackson County, Illinois. So Dr. LeBuhn travels to the Hopkinsville clinic about once a month, and I do to Jackson County, Illinois, so we can see people at different areas if they want to go out of the Paducah area. And then there are other Ryan White funded clinics, which is the federal funding that the clinic receives. in Henderson, Matthew 25, and then so we can refer them to other areas. It will require travel, which is very difficult for a lot of people. But Vanderbilt Clinic, University of Kentucky, and University of Louisville, and that's about it. There is a private practitioner in Carbondale, but that could potentially see some people if that was an issue. That person doesn't receive Ryan White funding, so then that's a little bit more difficult for someone who has no insurance and needs their medication through the state program and that type of thing.
So it is important for people to know that if you come to Heartland Cares, it is based on a sliding fee scale, and we're not going to turn someone down for care. That it's based on ability to pay, and that includes the medications. So I think that's very important, because I think sometimes, I know some of the medicines can cost tens and $20,000s of dollars depending on the regimen.
Right.
I would say too that most of the regimens now cost about $10,000 a year, maybe $7,500, something like that. So
that's reduced quite a bit.
On the grand scheme of cost, that's not. We spend a lot more on a lot of other diseases also, with a lot less chance of the same quality of life and outcome. So, I think people still have an image that I'm not saying that $7,000 to $10,000 is not a lot of money, but it's certainly a manageable number compared to what we spend on a lot of other
And the
other
cost
things.
effectiveness has been proven through studies.
Right.
Yeah.
You can, a couple of days in the intensive care unit and you've used up a year's worth of medicine.
Just going to the emergency room, it's very costly. So I feel like, and I know you all do as well, that we are providing a very vital service to the community, not just in treatment, but in, supporting the community and reducing costs, because it's a lot easier to take care of someone early on in their HIV status than it is if we get them via the hospital, which I know that still happens based on that discrimination. Do you see a decline in that at all?
I don't think so.
I don't know that I see a decline. I think we still have people who come to the emergency room with symptoms that are advanced HIV, that have severe opportunistic infections, and unfortunately that still is happening. And
So that's one of our biggest battles.
Yep, I
as
think
far as what we have to deal with.
Getting people to know that they're HIV positive too, if they have have had risk factors in the past, to get tested and to understand what their HIV status is very important. Even if they don't want to get care in Paducah, they just need to be getting care. And one other way I think the clinic and having the Ryan White Title III funding here benefits the community and the region in general is that the CDC is putting a lot of emphasis on focusing prevention efforts on people who know they're HIV positive. So really educating them on their responsibility in terms of minimizing spread of HIV and things like that. And the patients that we're providing care for get a lot of education from all the providers in the clinic regarding ways to curb the spread of HIV infection.
So what's coming down the pike? What do we have to look forward to? I know that we do tests now to see what types of medications that the virus might be resistant to.
Genotype testing or...
Tell me a little bit about that.
They're a little bit more sophisticated testing. There's HIV genotype and actually a phenotype, but it's, when we talked about resistance earlier, and it's generally people who've been on a regimen, maybe they didn't take the dose at the same time exactly every day, so they hit or miss with that medication. The virus has time to multiply again, then it's exposed to that medicine and it's learning how to outsmart that medicine. So then it changes itself genetically to where we can do a test and we can actually look at it and it will say, this has shown up, this has shown up. The virus has learned a way to outsmart this drug or maybe the other drug. And it helps us design our next regimen, which we didn't have that previously and it was too costly.
So it's not as much of a guessing game as to which regimen.
And now with so many more medicines to choose from, it's actually even more important. Previously, maybe 5-10 years ago, you only had one or two to go to. You had to go this route or that route. Now you really have a chance to plan out the next 3 decades for this person, and you want to make sure that this next change is going to last them, hopefully several decades. We have plenty of people on the same same regimen for 10 years now. I mean, I've been here 10 years in August, and there are people I saw in August or September of '98 that are still undetectable on the same regimen. We'd love it for everybody to be that way, but that's not the case. But you ideally want to think of it that way.
So if they take their medicines like they're supposed to, and the medicines are working, they're not going to as likely to build resistance and be able to take that medicine for the long
Correct,
period
because
of time.
the virus, if you suppress it to undetectable levels, to where our labs can't pick it up, there's really not enough virus floating around in their blood to outsmart the drug. It's kind of that little battle that if you keep it low enough, it can't outsmart it.
So we're getting close to running out of time. What are your recommendations to the community, and especially to anyone who might think that they need a test? I know it's...
I think if they feel like they need a test because of risk factors that they've had before, I think what Dr. Fleenor said earlier, you just got to go get the test. You get it out of the way.
Go do it.
And then you have to have some confidence in the fact that if that exposure was greater than 6 months ago, that test is negative, and use that experience to modify your future risk behavior. Don't put yourself at risk. Is I think very important. If you haven't been tested and you go get a test, you have to really understand that there are treatments available, there's clinics available, that not everybody will need medications, but that they need to get plugged into care. And I think for family members of people and friends for people who are HIV positive have to understand what a vital role they can play in supporting somebody and helping somebody, get into treatment and not be afraid of treatment, and help them when there's going to be stigma that they're going to run into, and there's going to be, unfortunately, still discrimination about some of that.
Okay, wonderful. Well, I can't tell you how much I appreciate your time today, Dr. Fleenor and Dr. LeBuhn, and I appreciate all that you do for the community and especially for the folks at Heartland Cares. And we've got a summary to put up to just help people remember what they can do, and hope you'll come down and visit us and see us. And that's it for today for HIV 101. Thank you very much.